turn the video on as well. Ooh.
There we go.
Oh, why is it green? Oh, that's not good. What happened to my... What's happened to my... That's not good.
Oh, it's fine now.
Oh,
So Anka is an alien, it seems.
oh.
So let's start off with this. So what do you see? Can everyone see the slides? Can anyone not see the... Tell me if you can't see the slides. If you can see the slides, tell me what you see. Yeah, I mean, you can see a foot, but yeah, more specifically, this is pedal edema. And when you see like edema in the peripheries, what is the question you want to ask yourself? Yeah, that's the most important question. Is it bilateral or is it unilateral? And that's because you get loads of different causes for bilateral versus unilateral edema. So let's pretend that this person had bilateral edema. What kind of things would you think of if you were looking at bilateral edema? Yeah, so the first thing you're going to be thinking of is heart failure. Nephrotic syndrome would also cause it. Why does nephrotic syndrome cause edema? Yeah, you reduce oncotic pressure as you lose loads of albumin. What else? Causes bilateral edema. So there's other things that work with the same mechanism as reducing oncotic pressure. There's another really important condition you need to know about. Yeah, so a chronic liver disease, which eventually will progress to cirrhosis, and that's in that case you're not synthesizing enough albumin. Yep. What else? You'll see lots of people with swollen legs. It's a very common presentation. So yeah, you don't need to know it for fourth year, but pregnancy is a very common cause of swollen legs. But yeah. And then lymph node resection, yeah. So is this edema or is it lymphedema? And the bilateral causes all tend to be systemic diseases. So you have heart failure, liver disease, nephrotic syndrome, all your failures. We spoke about some immobility. So immobility can cause it because of fluid accumulation in the legs due to gravity. That's probably the commonest cause, actually. So I haven't put that on the slides because I'm terrible.
Venous pooling is definitely the most common.
Yeah.
And you're that's kind of it becomes the reason why you're like at the end of like a long flight or something, you may see your socks indented onto your legs because it's just pulled there.
Yeah.
And it's the muscles that would cause the venous return. Which are not used.
And what kind of drugs do you know that cause this kind of picture? There's like a specific group. Yeah, so calcium channel blockers are really important. Often people are put on calcium channel blockers for hypertension, and then they go on to get like this edema, and then people are like, oh, do they have heart failure now? And then they get started on treatment for heart failure, but they just have edema due to the calcium channel blockers. So you need to be really like wary that that's another cause. And then there's also thyroid disease that causes everything in the body, as we talked about. It's just a mess, and it causes this thing called pretibial mixed edema. So lymphedema, you say lymph node resection is a cause of swollen legs, but if it's bilateral, you want to be thinking of like primary lymphedema, so like a congenital cause. We'll talk about that in a minute. You don't really need to know that much about it. And don't forget about venous insufficiency, which is very common in people older with smoking histories and arteriopaths. If they're unhealthy, they'll have venous insufficiency. What sign on examination would suggest venous insufficiency to you? I showed it to you a few weeks ago, I think. God, it's been weeks.
All the days are the same.
Yeah, so they get like this atrophic skin, venous eczema, which then goes on to become like lipodermatosclerosis. If you want me to type it out, tell me. What about some unilateral causes?
The unilateral causes are more likely to be associated just with that one leg. So yeah, the DVT and cellulitis is correct.
Easily the two most important ones, and then again you can have lymphedema, and this time it's usually secondary. So lymph node resection is more likely to be a cause of a unilateral leg, but yeah, always think about that if they've had surgery in the past. The most important things, the single most important thing to remember on this list is DVT. It's the one that will kill them the quickest. Fine. So case 1, Mr. Wale has just returned from visiting his family in Kenya. He's got a swollen left leg. What kind of what are you thinking of here? Mm-hmm. So it could be a DVT due to the flight. Yeah, definitely. He sat down for 5, 6.
Oh. Is he frozen? Anush?
Hours.
Anush, did you freeze there or did everyone else freeze there?
I may have frozen.
Nice.
Am I back?
Yeah, you're fine now. Okay, it was Anush that froze.
Sorry. What else could it be? So yeah, if someone who's just come back from traveling abroad, you should always keep in your mind parasites and weird tropical diseases. So that's another important thing. Those are the two most important things. But don't forget that just because someone's been abroad doesn't mean they can't also get like the standard infections. He might have gone climbing or something and got like cut his leg and now he has cellulitis. Like that could still be a thing. When someone's come back from abroad, you need to consider all of the current all of the weird tropical infections, but also like the normal infections that everyone gets all around the world. And yeah, this could be an immobility, but it's worsened since he landed, so that makes it slightly less likely. But yeah, it could very much be immobility, especially if it was just as he landed. So you got these. So the parasite you were all thinking of was filarial infections causing lymphedema. So this is what his leg looks like, and this is what filarial infections cause. Does anyone know which parasite causes this? So Ascaris is not that likely to cause it. There is a very specific parasite that causes lymphedema. So the challenge in this case is the fact that you need to be able to spell it, which is harder. So this lymphatic filariasis is caused by Wuchereria bancrofti. Yeah, exactly. Yeah, I can't pronounce it, sorry. It's like a parasitic worm carried by mosquitoes. You don't need to know this, but yeah, you can stain it at night if you get blood smear. It's only active at night. Oops. And management is albendazole and ivermectin, and that's a good couple of drugs to remember because most parasites you can kind of give those two drugs and they kind of work. So keep those in mind. This is pretty rare. You won't ever see this in the UK. It's just like an SBA thing. Yeah.
Which is why
Fine.
knows it.
I like infectious diseases. So what are the other causes of lymphedema then? What slide are you on? Sorry. Are other people having issues with slides? Ankit, what slide are you on?
I'm on 7. Other causes.
Okay, yeah. So what are the other causes of lymphedema? Oh, I forgot to put the slides in the chat. Let me give them to you. Sorry, I'm just uploading them. Yeah, so congenital causes are very important. What else? Someone mentioned another type earlier. Anyone else? Other causes? So someone already said lymph node removal. But I like to categorize them into neoplastic, iatrogenic, and congenital. So with neoplasm, you can have compression by tumors and compression of, by lymph nodes. And again, anytime anything's compressed by lymph nodes, you should be thinking of lymphoma. Then you can have iatrogenic causes. This is especially important for breast cancer surgery. One of the common side effects after breast cancer surgery is that they have poor lymphatic drainage and they get lymphedema in their arm. Do we have a definition of lymphedema? It's like failure of lymph to be to return to the central circulation, and it builds up in an area. I don't know if there's like an actual definition. Is there like an actual definition?
Not that I can remember, but I can have a look right now.
Yeah. Localized swelling of the body caused by abnormal accumulation of lymph.
Which isn't great, but yeah, it's kind of in the name.
Yeah, it's fluid in the extracellular space effectively, yeah. And radiation can also damage the lymphatic system and cause lymphedema. And does anyone know what the congenital cause of lymphedema is? You don't need to know anything about it. It's just an interesting thing that you might have heard of. This is what tends to cause bilateral lymphedema. It's called Milroy's disease. They just don't have lymphatic drainage in the legs sometimes, or part of their body. Right. Case 2. Well, enough of the rare stuff. So this is Mr. O'Shea. What did these two words mean?
Oh, this is bringing back memories.
So orthopnea is shortness of breath lying down. And yeah, paroxysmal nocturnal dyspnea means sometimes at night you wake up short of breath. Yep, precisely. And given the diagnosis, what is the most appropriate initial investigation? So here is a classic UCL question. The most appropriate initial investigation is not an echo. BNP is the most appropriate initial investigation. Echo
unless, so the NT-proBNP is the standard first line investigation unless they have a cardiac history.
Yeah.
So if they have a cardiac history, like they have had previous MI or they have arrhythmias or any ischemic changes or whatever, in that case you do go straight to the echo. Otherwise, it is the BNP first.
Yeah. So like UCL loves asking these questions. It's like, what is either the most appropriate initial thing to do, or what is the definitive diagnostic test? So if you were going to learn anything for like each condition, you want to learn the first thing you do and then the definitive thing you do. Yeah, the best thing you would do. So yeah, the diagnosis is congestive cardiac failure, and the most appropriate initial investigation is BNP.
Yet. Oh no, it's feet. Sorry, I didn't see the feet.
It's likely to be congestive cardiac failure. You can't actually diagnose it without echo results, but yeah.
Also, just generally, heart failure isn't a diagnosis. It's a symptom. It's what the patients are experiencing. The diagnosis is going to be the thing that's causing the heart failure.
Yeah.
It doesn't just happen by itself. So it may be secondary to ischemic changes in MI, or it may be they have anatomical changes, with
Cardiomyopathy.
a cardiomyopathy or regurgitating valve or something like that, that's going to be the diagnosis.
Yeah, it's like a presentation rather than an underlying cause. There's like a differential diagnosis for the cause of heart failure, although one of the causes can just be degenerative as you get older. So this is heart failure.
Frozen again. Oh.
Yeah.
You froze again. You wanna?
Am I back?
You're back now.
The slides have. Okay, fine.
Repeat the last bit.
Lots of people asked if we can go over heart failure. So the most important question I'm gonna ask is, how do you classify heart failure? Failure. Would you do BNP with or without the history of cardiac problems? So if they've got no history of cardiac problems, do BNP first, then echo. If they've got a cardiac history, you can go straight to echo. But like echoes take time, and in real life, they'll probably get a BNP again. Yeah. So Izzy, one of the ways you can classify is according to severity. How else can we classify it? There's loads of different ways. So we can look at the ejection fraction on the echo. Is it high output or low output? What else?
Called HFpEF and HFrEF.
So symptomatic is basically associated with severity.
And which side?
You can do which side of the heart. Yeah, those are the important ones. There is one other type, which is systolic versus diastolic failure. Like, is it a failure of the heart to pump blood out, or is there something stopping it from filling as well? So there's lots of different ways.
The systolic versus diastolic is basically related to the ejection fraction as well. Because I'm sure we'll cover it in a second. So I'll wait.
So we went through this, and also don't remember there's also acute versus chronic. Someone presenting with acute heart failure, your priority is to get the fluid out of their lungs, use an A to E approach, and that's one of the emergencies you should definitely learn, because it can come up not in your lack of OSCE this year, but it can still come up in your exams. So severity is, I think this is what you were getting at. You can look at their symptoms, and this is the New York Health Association's.
No, is it Health Association?
I thought so.
Oh yeah, it is. You're right. No, Heart Association.
Heart Association classification. Learn this for your exams. It's quite good. Basically, symptoms at rest is severe. The other ones are just an increasing magnitude of symptoms.
Usually, that's the case with quite a few like classification systems. You'll need to know the most basic one, and you'll need to know the most severe one. They're not really going to ask you like level 2 versus level 3 or level 3 versus level 4, because that doesn't tend to inform management so much.
Yeah, like PassMed likes to ask about it, but UCL is less likely to ask about it. And then right versus left. So left-sided heart failure, you get backflow of blood back into the pulmonary circulation.
So what do you like to get as a result? Oh yeah.
Yeah, what symptoms are you going to get? It's almost like I planned this out, Anke.
Yeah, it's like there are questions.
So pulmonary edema, and then the symptoms are things like orthopnea and PND, as we discussed. And yeah, it's not so much pulmonary. So there's an increase in pressure in the pulmonary circulation, which causes fluid to go out into the lungs and cause pulmonary edema. And so less so. Yeah, they tend to be less well perfused, but anyone with heart failure does tend to be less well perfused. So yeah. And don't forget the signs as well. You'll get a raised JVP, which is remarkably useful.
Raised JVP is more right-sided, isn't it?
I think it's left-sided. I think it's both, actually.
I mean, the JVP would be venous system, so it would have to go all the way around to the right side to track back up, no?
Yeah, but I think because it's actually pretty close to the lungs that like you do get a raised JVP in left-sided as well.
Okay.
And then right-sided heart failure signs. You get JVP in both, basically. I mean, right-sided versus left-sided is pretty academic generally. It's just like an exam thing. Peripheral edema, hepatosplenomegaly, pedal, sacral edema, yeah, you know the drill. Fine. And when you're diagnosing heart failure, before you go on to your BNP, unless you're in GP, because in GP you don't have time to do anything else, don't forget history, examination, bloods, ECG, you know, like the standard stuff. So examination findings for patients with heart failure. Can you give me some findings that you'd get?
Yeah, raised JVP.
Raised
Crackles.
JVP, yeah. Crackles.
Are you more likely to find unilateral or bilateral crackles in this?
Yeah. Which one?
Yes.
Yeah, bilateral crackles. And how would you describe the crackles to the examiner? Not that you have an OSCE again.
Yeah. It would be coarse.
Coarse, yeah, coarse crackles. Hepatomegaly.
Fine tends to be more along the lines of fibrosis. Coarse tends to be things like infiltration from infections or from edema.
Yeah. If the cause is valvular, then yes, you definitely get all of the associated findings for the valves.
Interesting. Even if it's not valvular, what heart signs, cardiac signs are you likely to have?
Mm-hmm.
So what does the S3 gallop mean? Yeah. So you get two extra added heart sounds. S3 is due to just basically increased volume. So increased volume of blood rushing through the valves and the ventricles. The gallop just means it's that plus tachycardia. You can also get S4, which occurs in some cases when you have a constriction of the ventricles. So it's like it's banging against this hardened wall. So that's what the S4 does, and the S3 is because of the turbulent flow, which means you can get S3 in the range of conditions that we talked about slightly earlier, which may cause like a hyperdynamic state.
Yeah. S3 is also can also be present in pregnancy.
Yeah, like that.
Yeah, the important ones that you are likely to pick up in examination are these ones. So raised JVP. Don't forget that their apex beat is often displaced because they've got ventricular hypertrophy. Coarse crackles. What's pulses alternans? This is really noticeable, by the way. Like people are like, oh, you can't pick up pulse signs. You can pick up pulses alternans. Yeah, exactly. It's a strong pulse than a weak pulse. It's really obvious when this is one of the obvious pulse signs alongside the water hammer pulse.
So if you have a displaced apex beat, what's that going to mean for the ECG?
Yeah, I mean, yeah, that was going to be my next question.
Oh, I'm sorry.
No. Perfect. That means the questions are obvious, and the question should be obvious. Yeah, you'll find axis deviation, and so in left ventricular failure, which tends to override, is the most like abundant finding. If you've got congestive cardiac failure, what axis deviation would you find? So the left ventricle is bigger than the right. Yeah, you get left axis deviation. Exactly.
So a really quick way of just general ECG things is if, sorry if you guys already know it, but if you see a positive deflection on an ECG trace, that means there's electrical activity coming towards that electrode that you're looking at. If it's negative, it means it's going away, which means you can, the way I work out axis deviation is by just making a grid like this. So if you look at lead 1, it's going across the heart, right? And then if you look at AVF, that's going straight down, right? And for you guys, it'll be this one. So the bottom right quadrant is where the normal axis is meant to be, which means lead 1 would be positive, right? And AVF would be negative. So there'd be a negative deflection on that, right? If both of them
have a diagram
positive, yeah, do that. If both of them are positive, it's up here, which means left axis deviation. And if lead 1 is negative, and this is negative, that means it's right axis deviation, if that makes sense at all.
That is the best way of doing it. Let me post a diagram that will make it easy for you.
Rather than doing this.
Rather than Ankit doing his fancy dance. Dance.
That's good. Yes, exactly. So if you think of the horizontal line across that as lead 1, and if you think of the vertical line down that as AVF, I mean, yeah, you get the traces as well.
Extreme right axis deviation. ERAD is extreme right axis deviation.
Yeah.
This diagram is really useful. Like for cardiology, signs are really useful. ECGs are really useful. I think those are like the most useful things in cardiology.
Also, just generally, to just slip this into your exam, always check their legs, right? One, you will obviously get the edema, but also look for that cabbage scar. Because that tells you so much.
Yeah.
Just
I know you don't have an OSCE this year, but you're going to have an OSCE at some point.
And I guarantee you the cardiac exam is the most commonly assessed one.
Yeah. Fine. And then the next, after you've done all of your like baseline stuff, you're going to measure proto-BNP. And you all probably, those of you who have done PassMed will know this. If it's really high, echo them in 2 weeks. If it's in the middle, echo them in 6. And the echo is really important. It allows you to definitively measure their ejection fraction. So that's where you're getting your diagnosis from. It's also useful if you've got valvular disease. Yep. You can pick up valvular disease, so you might get an underlying cause as well.
So what do you do if you're trying to echo someone and they're really fat and you can't get a good image of the heart? You know, you're echoing them and it's just you can't get it on the front. Exactly.
Yeah, exactly. You go through the esophagus.
And that's actually the gold standard. That's where you can ensure a diagnosis. But generally, you know, it's more invasive. NT just stands for N-terminal, and proto-BNP is just a pro form of BNP.
Yeah. So just quick revision. So BNP stands for brain natriuretic peptide. It's actually produced both in the brain, but it's also produced within the left ventricle, and it relates to ventricular stretch. If you've got heart failure, you're more likely to have more fluid within your heart, your ventricles stretch more, and you get a higher BNP reading. So that's why it's suggestive of heart failure.
So do you guys know of any possible causes of a falsely low BNP? That's one.
Obesity is one of them.
Yep, that's another.
ACE inhibitors is another cause.
I'm not sure about renal failure.
I shall check.
Yep.
Is there a specific one you're looking for, Ankit?
No, I'm just going through the list. It was the ARBs, ACE inhibitors, diuretics was the other one I knew, and obesity. Those are the main ones.
So decreased renal function actually results in increased BNP, not decreased. Were we going through increased or decreased?
Decreased. Falsely low.
Yeah. So it'll be falsely high. They're in renal failure. And this is one of the only conditions where I think that like understanding physiology is like key. So heart failure is effectively reduced cardiac output. There are two ways the body copes with a low cardiac output. What are those two ways? Excuse my terrible drawing. It's just it's easier. So one of the ways is using the renin-angiotensin-aldosterone system, the RAS system, and that allows us to retain fluid and increase the circulating volume. The other way is to increase systemic vascular resistance. And what system do we use to do that? So yeah, it's the sympathetic nervous system, and alongside vasoconstriction, what that also does is it raises our heart rate, as you said. So that's pretty much beta receptor controlled. There's other receptors involved, but yeah, it's mainly beta receptors. But the problem with vasoconstriction is it increases cardiac work, as does retaining fluid through the renin-angiotensin system. So you've got an increased preload and you've got an increased afterload. So remember that the preload is how much fluid is going into the heart that it's going to go then pump out, and then the afterload is the pressure it's pumping against. If you increase cardiac work, it has to the heart is working harder, and the heart rate has gone up, as we talked about already, and that causes myocyte damage. And you start like this vicious cycle where your cardiac output is lower, you activate these systems, you increase the work the heart needs to do, you get more myocyte damage, which worsens your cardiac output. It just gets worse and worse and worse and worse. So now that you've got this diagram,
one of the additions actually, just around the middle of the myocyte damage, one of the results of this is cardiac hypertrophy. That's what causes the axis deviation, and that causes a bunch of problems as well, because if it's whatever the cause of the reduced cardiac output is, both of these systems cause the hypertrophy, and that hypertrophy can go unregulated, which means you can get a full-on cardiomyopathy as a result.
So now, like, does the physiology of that kind of make sense? If it does, what kind of drugs can we use to stop this cycle from continuing and spiraling out of control? You have two pathways. What can we use to block them?
Given you the
so ACE inhibitors will block the top pathway. Beta blockers will block the bottom pathway. So those are the mainstays of treatment. But before that, you've got pulmonary edema. So what are you going to do to get rid of that? Diuretics, exactly. And that's literally heart failure. Diuretics acutely and get rid of all the pulmonary edema. When they're stable, you start them on both an ACE inhibitor and a beta blocker to stop both pathways. And then if they have persistent symptoms, you refer them to a specialist. And the specialist can start them on loads of specialist drugs, digoxin, nitrates, like loads of like weird drugs. And you can go and read up on that yourself. I'm not going to put that all in a slide, but this is the important stuff that you need to know. What happens if they start coughing? They get a dry cough after you start them on these drugs.
Ooh.
Yeah, switch them to an ARB. It's probably a side effect of the ACE inhibitor. Yeah.
What about if they get massive facial swelling?
Good question.
What's it due to?
Yeah. ACE inhibitors can classically cause angioedema. Yeah. ACE inhibitors cause some weird side effects.
Yeah.
So here's another case. It's meant to say teeth. I don't know why I wrote tweet. The slide has changed. We're on case 3. It is not ptosis, but I understand why you have said ptosis. We spoke about this a couple of weeks ago. We've done this. Ptosis is a good answer though, but it's not ptosis. SVAs would make it a lot more clear cut. It's just my bad case writing. So yeah, the main finding you'd find a mix of upper motor neuron and lower motor neuron signs, because yeah, this is likely to be motor neuron disease. This is one of the things that these people tend to get. They tend to notice weakness in their grip, and tongue fasciculations are quite specific for motor neuron disease. Yeah, they would also get no sensory loss, but remember, positive findings before negative findings. That is a salient negative there. As an nanoscopy, you should definitely say that. What else would you find on examination? So you've got mixed upper and lower motor neuron signs. You've got a twitching tongue. You'd also get twitching elsewhere in the body. So don't forget that. What drug would you consider starting Miss Violet on? Riluzole, yeah, exactly. And riluzole is this really expensive drug that prolongs the need for ventilation by maybe 6 months. So, as in she's pretty young, so you would definitely start her on it. But yeah, this is not a good prognosis in terms of diseases. We've already covered
one more actually. A couple more signs that are quite important is that you can get speech changes. So one of the which one is it for? You get a speech change which basically makes the person sound like Donald Duck. So it's like Donald Duck speech change.
Who took control of my slides?
My hands are away from them. It's not me.
Someone else is ruining my day. Yeah, so speech signs are also a part of motor neuron disease. They are less common, but yeah, that can also happen.
It's more of it's a lower motor neuron thing in like a bulbar palsy, but yeah.
Yeah. What other neurological conditions should you consider when someone has a change in their speech? What other conditions cause change in speech? So stroke is like the #1 thing. They tend to like really struggle to enunciate. The other one alongside stroke is they can have issues in Parkinson's as well due to the tremor. Fine. Miss Violet returns 2 months later. She comes in with vomiting, having been laughing for 30 minutes straight. What is going on? You ask her why she was laughing for 30 minutes straight, and she's just like, "Oh, my friend just said something really funny." Does anyone know? Relaxation of lower esophageal sphincter. So that is what's causing her vomiting, but that doesn't explain her laughing for 30. Like laughing for 30 minutes isn't really like a small thing, like without a break. So yeah, this is pseudobulbar affect, and this is something that can occur independently, but can also occur in up to 50% of cases of motor neuron disease. Most people don't present with it. But it's characterized by uncontrolled bouts of laughing or crying. Doctors call it emotional incontinence. And patients aren't really warned about it, so it kind of catches them off guard. There was someone at the Royal Free last year who presented with this and ended up having motor neuron disease. So yeah, just remember emotional incontinence is pseudobulbar affect. Does anyone know the difference between mood congruent versus mood incongruent? It's more a psychiatry thing next year, but someone might be interested. So mood congruent is where, for example, someone does actually say something really funny and they continue laughing for 30 minutes. Mood incongruent would be someone says something really funny, but they just end up crying. Like it doesn't match the stimulus. Okay, if we just go back a second, someone said ptosis. What condition were you thinking of when you said ptosis? Myasthenia gravis is, yeah. So that's when someone else has muscle weakness, and if it's worse during the end of the day, or like they get quieter speech at the end of the day, they struggle to talk, things like that, you need to think about myasthenia gravis instead. Fine. The reason I brought up motor neuron disease again, so we can cover some CPP stuff. Motor neuron disease is incurable and rapidly progressing. What else do you want to discuss with Miss Violet at this stage? So
Sure.
palliative care is exactly what you want to discuss, and the ceiling of care.
And the advanced directive in LPA,
Yeah. So when someone still has capacity, as she does at this stage, you want her to make the decisions of how she wants to be cared for in the future when she might not have that level of capacity. And unlike the med school, we're not going to spend like an hour on this. We're going to spend 10 minutes on it. And
which is what they should do.
Yeah, like they should do as well. But remember that there are 4 steps to assessing capacity: understand, retain, rationalize, and communicate. If someone can't do any one of these stages, they automatically don't have capacity.
And before this, there's assumed capacity. So there needs to be a trigger to inform a capacity assessment, to kind of push you to do a capacity assessment, and then you do this. Otherwise, it's just generally assumed.
Yeah. So those are the 4 steps of assessing capacity. So what kind of things?
Good. You were going to ask something. I thought you forgot.
What was I going to ask?
No. You just said what would, and then I cut you off. Sorry.
No, it's fine. What different things can we put into place to help Miss Violet ensure that she gets the treatment she wants? So what things can we do? What things can we do? Oh, someone's already written it. Sorry. So yeah, you can do advanced directives, or you can do a lasting power of attorney. Some of these are legally binding. Some of these are not legally binding. Which 2 are legally binding? Am I frozen?
Nope.
Just checking. My internet is being temperamental.
Not ideal.
So what legal things can you put into place that are legally binding and the doctors have to use it? Or has the chat frozen?
No, I don't assume so. Mm-hmm.
So DNR is a specific type of one of these. So yeah, DNAR is definitely legally binding.
The thing is, that's not down to the patient's wishes. The DNR is a clinical decision. So it's really important, and it's really stressed how when you're talking about a DNR, it's not asking for permission to put a DNR form on someone's folder or file or whatever. It's explaining to the family that you are doing this, that it's the clinical decision in their best interest, but you're not asking for permission. Whereas the things that we're talking about with Anush are things that are within the patient's control, that they can do.
Yeah. So advanced decision is one of the legally binding things. Yeah. And then the other legally binding thing is a lasting power of attorney. If neither of those things exist, you go on to make a best interest decision, and that's done by the clinical team.
Or if you know, there's some dispute or whatever, you can get a representative of the court to do that as well for someone.
Yeah. So advanced decisions, I would recommend that you remember this as advanced decision to refuse treatment, because the only thing you're allowed to do is refuse treatment. You can't use it to demand treatment or suggest that the doctors take a certain approach to treating you. The only thing you can do with this is deny specific treatments. And this is a legally binding document that doctors have to follow. So learn this as an advanced decision to refuse treatment. It's like, it'll save you time in an exam because it won't let you get confused with the other similarly named thing.
Really importantly, what can they not refuse in this?
Does anyone know?
Which are food and drink. So food and drink is one. What else is basic care? Not life-sustaining treatment. They're allowed to reject life-sustaining treatment, but they can't reject basic care. So dressing, washing, food and drink, yes.
Yeah. And then you have the advanced statement, which is, and people get these two very confused sometimes. This is not legally binding, and it's just like it's just like a document you write down any feelings or wishes that are important to you about how you want to be cared for in the future. It's up to your family and the caring team to make decisions based on this. They'll use this when they're making the best interest decision, but it's not legally binding. So keep that in mind. And
what happens? Oh, sorry, I was just going to say, what happens if you make an ADRT to refuse something, and then when that is offered to you, you accept? What happens then?
Wait, what was the question? I wasn't listening halfway through.
Nice. You make an advanced decision to refuse something, and then later on in your pathway, that thing is offered, and you accept it. Then what happens? Sure, capacity assessment, yes. And if you have the capacity, it overrides. Yeah, that's what I was trying to get at. It's always the most recent decision that you've made with capacity that counts.
Yeah. So similarly, we will talk about another thing that happens with this. So lasting power of attorney, you have two separate ones: health and welfare, property and finances. The only person that can make a decision about your healthcare is if you give them health and welfare. Someone with property and finances cannot decide about your healthcare. This is a legally binding situation where you give another adult, it's usually a family member, the legal authority to make decisions about your care. So what happens if you have an LPA and you have an advanced decision? Exactly. So the most recent one will override the other one. You would hope that the LPA was chosen as such that they agreed with the person, though. So like they should technically match. And like sitting here and thinking about it, this all seems very straightforward, but like decisions like this are very difficult. Like if you were at uni, you'd have like a workshop on this, and like there are lots of debates had about this. It's really hard to like figure out exactly what patients want sometimes.
And what's important is with someone who has an LPA, that LPA has essentially the same rights as the patient, but also the same limitations. So just because someone has an LPA doesn't mean they can demand certain treatments, because that patient wouldn't be able to demand treatments with capacity anyway. So they can refuse treatments. That's all they can do, because that's all the patient could do.
Yeah. And I guess we'll briefly go back to do not attempt resuscitation. So as you said, it's like a specific type of advanced decision that is initiated by the doctors based on what they think is in the best interest of the patient. Just think about resuscitation like this. You wouldn't offer a patient treatment that you know isn't going to work generally, and a DNAR is just an extension of that. You don't think resuscitation is going to work, therefore you're not even going to offer it to them. Therefore, you need a DNAR form. And patients will need separate DNAR forms in the community and separate ones in the hospital. And on each admission, they need a different DNAR form. Does that make sense? Any questions about that? It's just a really specific scenario that is very important. They love asking about. This is the kind of stuff they love asking about in exams. I'll show up about CPP and run through the last bit if there's no question. So what is this?
The patient sign it. No, the patient doesn't sign it. The doctor
Patient
sign
doesn't.
it.
Yeah. This is clubbing, and you can tell because there is a loss of the nail fold angle, and there's lots and lots and lots of different causes of clubbing. So tell me about some causes of clubbing or categories of causes of clubbing.
Best mnemonic for this is just great. Oh,
I never used a mnemonic.
I'm sorry. A new big brain doesn't need mnemonics.
I just like categorizing stuff.
Additionally, just a quick side point going back to the heart failure. Did you cover X-ray signs?
I covered it last Friday.
Oh, okay, that's fine then. Don't worry.
We can go through it at the end really quickly if anyone wants. Drop a message if you do. So of the lung, lol. Yeah. So remember, if anytime anyone asks you a question in like any sort of communication exam, remember to split it up into categories. So yeah, you can have cancer of the lung, or I would put it into a category of just respiratory conditions causing it. So what other respiratory conditions would cause clubbing? So you've got lung cancer.
Yep.
Bronchiectasis is the other major cause. Yeah. What else? Lung abscesses can cause it as well. Yeah. Pulmonary fibrosis can cause it. Yeah. So I think those are the big ones.
Cystic fibrosis.
Yes.
And
cystic
very,
fibrosis.
very importantly, not COPD.
Yeah. So yeah, cystic fibrosis causes bronchiectasis in the lung. Therefore, it causes clubbing. Yeah. What other manifestations do you get with cystic fibrosis now that you've mentioned it? Sorry, I'm just... What are the other manifestations of cystic fibrosis? Yeah, they get diabetes because they can't secrete the enzymes properly.
Pancreatic insufficiency.
Yeah. So they need...
Creon is the best, is the coolest name of any medicine ever.
Yeah. If you see Creon, it's just pancreatic enzymes.
Yeah.
With a fancy word. Right, so we've done respiratory causes. Let's do cardiac causes next. What are the cardiac causes of clubbing?
The easy way to think about this, and it's actually quite specific, is that it needs to be things that cause cyanotic heart disease. Exactly.
So cyanotic, I mean, you got it immediately. So atrial myxoma is the rare cause, tumor within the atria. Cyanotic congenital heart disease and infective endocarditis. I put ish because like it might not actually be all of the fingers in infective endocarditis, but yeah, it is definitely a cause.
So importantly in this, can you give me examples of cyanotic congenital heart disease, specifically the cyanotic ones?
Yeah. Tetralogy of Fallot is one of them.
Mm-hmm.
What else? Patent foramen ovale is not actually.
Anytime if there's just a big hole within the heart, right? The left-sided pressure is going to be higher than the right-sided pressure, which means the oxygenated blood is just going to go back into the right side and carry on going round. So that's not going to cause cyanosis.
Yeah.
Which is
so
why,
same thing with patent duct.
Same thing with ASDs and VSDs.
Yeah.
Unless there is a change, so it becomes right-sided dominant. So the right-sided pressure increases so much that it starts pushing the other way. So Eisenmenger's, for example. Yeah.
Aortic coarctation, no, not really. To be fair, you might not have heard of the other one.
Transposition.
Of the great arteries.
Yeah.
Have you heard of that? It's basically switch the what do you switch? The aorta and the pulmonary artery. I had to think about it. Yeah, that's basically a transposition of the great arteries. Those are the only two like always cyanotic heart lesions. Fine. GI causes. Inflammatory bowel disease is the biggest cause. Yeah. Celiac disease can also cause it. I didn't put it on the slide, but it definitely can. And cirrhosis. Yeah, those are like the big. Those are the big two. But yeah, celiac disease definitely causes it as well. Cirrhosis of what cause is most likely to cause clubbing? Sorry, we're going to run over by like 5 minutes, but I promise it's only like 5 minutes. So surprisingly enough, not alcoholic. It's remember we went over primary biliary cholangitis. When that progresses to cirrhosis, that's like the most likely cause of cirrhotic clubbing. But you don't need to know that, it's fine. It was just a fun question. And then you have like the odds and sods group of thyroid acropathy and congenital clubbing. Thyroid acropathy is important, congenital clubbing is not important. But if you're ever stuck in an OSCE that you don't have this year yet again, congenital is always a good get out of jail free card. All right, what's this? Ooh. Ooh. This is honeycombing of the lung, yes. What is that suggestive of? Yeah, so this is fibrotic changes in the lung. And when we talk about fibrosis, we split the causes up into apical and lower lung fibrosis. So I've given you the acronym there. What are the causes of apical lung fibrosis?
Oh, nice. You use breast. I have a different one. I also have one for the lower, though.
You don't need to know the one for lower. Lower is like useless. So causes of apical pulmonary fibrosis. This is one of the few mnemonics I actually use. What's the B? Beryllium, yeah, that the B is kind of weird. Spoilers, I just gave you all of them. Radiation, yeah. So any head and neck cancers, if you have radiotherapy for iodine, you can get like a bit of apical fibrosis. What's E? I accidentally showed it to you for like a second.
You weren't paying attention.
Yeah, extrinsic allergic alveolitis, and yeah, it can be eosinophilic as well. So yeah, that's what E is. A,
which is also called hypersensitivity pneumonitis.
Yeah, A is ankylosing spondylitis. What is S? S is sarcoid, yeah, and then T.
S is also silicosis.
Yeah, and T is TB because TB is important. But also don't forget that A can also be allergic bronchopulmonary. That's not meant to be alveolitis. That's meant to be aspergillosis. Sorry, I made these slides at like midnight. But yeah, so aspergillus can also cause the A. But yeah, ankspond as well, definitely. And then I remember the lower, like the causes of lower lung fibrosis. It's all of the groups of causes. So what groups of causes are there for lower lung fibrosis? Like groups of conditions or groups of other things?
Yeah.
Yeah, so drugs, yeah. So what kind
of
drugs? Give me some drugs. That sounds wrong.
Some of Anusha's favorites are in this. Yep.
Yeah, methotrexate and amiodarone, which are like my favorite drugs. Exactly.
Some more bleomycin.
Bleomycin
is a chemotherapy agent.
Yeah.
Nitrofurantoin, right? Which is an antibiotic.
That you use for chronic UTIs.
Yep, and also sulfasalazine.
Yeah. But yeah, the big ones to remember are methotrexate, amiodarone, and nitrofurantoin. Those are the big three.
Definitely.
Okay. What other groups? There's one other big group of diseases that causes lower lung fibrosis. Yeah, so it's all of the connective tissue diseases.
Mm-hmm.
So rheumatoid
Except
arthritis
Bond.
and sarcoid. So yeah, rheumatoid arthritis, lupus, vasculitis, all of those can cause like lower lung fibrosis. Is the slide going to change?
Nope.
My internet's just dying, sorry.
I think I remember asbestos being...
And asbestos, yeah, it's on the list.
Important. Yeah. if it ever shows up.
Yeah, if it ever shows up, yeah. So idiopathic pulmonary fibrosis also tends to be lower lobes. And asbestosis causes lower lung fibrosis. What are the characteristic X-ray changes for asbestosis? There's one specific sign you get on X-ray. Begins with the letter P. So they get like pleural plaques.
Mm-hmm. Which is it's not, increased risk.
Not pre-malignant.
Yeah, it's not pre-malignant, but the way to remember it is that it's affecting the pleura, and asbestos gives you far higher chances of mesotheliomas.
Yeah. Let me just give you a photo of it for your notes or whatever.
What's the most dangerous type of asbestos? This is from PassMed.
This is such a useless piece of information that PassMed likes to test. That's what pleural plaques look like.
Yeah, that's the one. Yeah.
Yeah, blue asbestos is the most dangerous type. UCL is never going to ask you that question.
They're not. They're really not.
Okay. So that's all the cases we were going to go through today. I've put a feedback form in the chat. If you could fill that out, let us know what you want us to cover next time. I was going to say something else based on something Ankit said earlier, but I can't remember what it was. So I guess not.
Just repeat myself.
If you have any questions about anything we've covered, or you want us to go back over anything, just let us know.
Mm-hmm.
But yeah, learn heart failure, learn like lung fibrosis. Those come up a lot, and learn CPP.
Comes up a surprising amount.
Much thanks.